Let's welcome Dr. Tong.
Hey, thanks, June. Good afternoon. My name is Pearl, and I work with the Division of Gynaecology at NUH. I would like to thank the organizing committee for giving me a chance to share my experience with pre-peritoneal wound catheters for management of post-op pain in this symposium. I have no conflict of interest to declare. Okay, here I will divide my talk into 3 sections. Introduction as to why we are discussing this topic, developing our technique. I will share our local NUH experience, as well as analysis of our first 46 cases. Okay, in the introduction, I will cover the background of why we decided to use pre-peritoneal wound catheters for infusion of local anesthetics for management of post-op pain, and give you an insight into the existing literature on the evidence for use of these LA wound catheters and evidence specifically for gynaecologic cases. Now, we know that laparotomies are associated with severe post-op pain due to stimulation of nociceptive receptors on the abdominal wall. These can come from all layers, including subcutaneous, musculofascial, and parietal peritoneal layers. Pain then leads to various physiological effects like tachycardia, increased respiratory rate, stress responses like hyperglycemia, increased cortisol production, decreased intestinal motility, just to name a few. To counter this problem of pain, multimodality post-op analgesia has been described. Broadly speaking, they consist of opioid and non-opioid drugs, and the usage of non-opioid drugs help to reduce opioid-related side effects like nausea, vomiting, ileus, sedation, respiratory depression. So this diagram provides an overview of post-op pain relief. Now, I am not an anesthetist, so please pardon me if there are any mistakes here. So there are oral and systemic options. For oral medications, there are the opioids, for example, tramadol, oxycodone, and the non-opioid medications, for example, paracetamol, NSAIDs like naproxen, diclofenac. With regards to the systemic options, I've broadly divided them into 3 categories: intravenous, peripheral, and central nerve blocks. For intravenous analgesia, they can be divided into opioid and non-opioids again, and the opioids can be administered as boluses or infusion, and even as patient-controlled analgesia, what we know as PCA. Peripheral nerve blocks work by blocking transmission of pain from nociceptive efferents from the wound surface, and also inhibiting local inflammatory response to injury that can sensitize nociceptive receptors and contribute to pain or hyperalgesia. So these nerve blocks can be performed at different proximity to the central nervous system, and in general, the nearer to the spinal cord, the more effective the area of block would be. So central nervous blockade can be done via epidural or spinal anesthesia, either given in boluses or infusion with the option of PCA as well. Often these nerve blocks are used to complement intravenous pain relief that is achieved with opioids, because opioid use can cause side effects like post-op nausea, vomiting, and lead to major patient discomfort, poor satisfaction, delayed discharge, increased nursing care, etc. So I've put out some evidence with regards to the use of continuous wound catheters delivering LA for post-op analgesia. So this study by Spencer Liu et al. Contains one of the largest series of patients. It is a systematic review of 44 randomized controlled trials involving more than 2,000 patients. They have included only wound catheters that are placed by surgeons into the operative field. Hence, it will be limited to rectus sheath, pre-peritoneal or subcutaneous layers. A variety of locations were included in these studies, and also multiple specialties of surgeries were involved, with a median mode of 2 days usage of the wound catheters. So the summary shows consistent demonstration of analgesic efficacy in terms of reduced pain scores or opioid use for all surgical subgroups, despite its heterogeneity in locations, dosages, and analgesic mixtures. And there's also a global reduction in post-op nausea, vomiting, increased patient satisfaction, and decreased length of stay. So this next paper by Sophie Liang is a Cochrane review of local anesthetic wound infusions after midline laparotomy for colorectal resections in adults. So there were 6 randomized controlled trials with a total of 500 patients analyzed. Continuous wound infusion with LA is compared to normal saline placebo in all the RCTs. The placement of catheters, however, differed. So in 2 trials, catheters were placed supraflexually in the subcutaneous layer. In 1 trial, it was placed in the musculofascial layer, and in 3 trials, it was placed in the pre-peritoneal layer. So the results are summarized in this table. I know it looks very busy, but I'll draw your attention to the right-hand column depicting the certainty of the evidence. So I've circled the ones with moderate and high levels of evidence. This means that the authors were very confident that the effect estimates for these outcomes lie close to the true effects. So there is high certainty that the usage of pain catheters reduce pain score at rest on post-op day 1 and the length of hospital stay. There's moderate certainty of evidence to indicate that intervention probably reduces opioid consumption via PCA and the time to first bowel movement. Now, how does this compare to central nervous system blockades, and where should the catheters be placed ideally? Injecting only in the subcutaneous layer may be insufficient because it limits blockade of parietal nociceptive inputs to the superficial layer of the abdominal wall, missing the fascia of the abdominal muscle and peritoneum, which are also richly innervated tissues. So pre-peritoneal layer is another layer that some studies have explored, thereby blocking peritoneal afferents and helps reduce pain. So a systematic review and meta-analysis by Timothy Mungroup and his group here helps to shed some light on this matter. So they included 29 RCTs with more than 2,000 patients. This was divided into 4 subgroups. The first compared pre-peritoneal versus subcutaneous continuous wound infiltrations. And one study was found and showed that the pre-peritoneal catheters led to better pain control than the subcutaneous catheters. The second would be of most interest to us, comparing pre-peritoneal catheters versus active controls, meaning patients who are using epidural analgesia and PCA. That included 13 studies and showed that pre-peritoneal wound catheters provided comparable pain control compared to active controls. The third group compared subcutaneously placed catheters with active controls and showed that active controls were superior in terms of pain control during movement. Interestingly, the last group comparing continuous wound infiltration versus saline showed variable outcomes. So the authors made the conclusion then that recovery parameters, opioid consumption, incidence of hypotension, and patient satisfaction seem to be in favor of pre-peritoneal wound catheters compared to active placebos or active alternatives. So continuous wound infiltration with pre-peritoneal wound catheters is an effective pain relief modality in abdominal surgery, and the pain control is as effective as epidural analgesia but could be favored based upon recovery parameters and patient satisfaction. So to put it simply, pre-peritoneal wound catheters compared to neuraxial analgesia is associated with more patient acceptability and comfort, less concern about motor blockade, less serious side effects like epidural hematoma, especially with patients on anticoagulants, less time taken for administration, less chance of failure, less expensive, and probably less skill required. Okay, the next 2 papers describe continuous wound infiltration systems specific for gynaecologic surgeries. This Korean paper compares pre-peritoneal infusion of 2 mL per hour, 0.5% ropivacaine for 72 hours with IV PCA fentanyl versus IV PCA fentanyl only. Note the relatively small numbers of 31 in each group. They found that post-op surgical site pain score for the first 72 hours was lower in the combined group, which is throughout the duration of the pre-peritoneal infusion, but no difference in PCA usage and side effects such as nausea, vomiting, dizziness. So in the discussion, it was mentioned that the difference in BMI in both groups and patient selection bias may have contributed to these results. The next paper is also a Korean paper by Don Chong et al., comparing continuous wound infusions versus PCA fentanyl. It sounds similar to the previous study, except that the continuous wound infiltration arm does not have PCA fentanyl. Numbers are even smaller in each group. They use 10, and post-op pain scores will be found to be lower in the continuous wound infusion group. So after looking at the efficacy regarding pre-peritoneal catheters for infusion of LAs, I would briefly touch on the rationale behind our local setup before going to the details. So with regards to the choice of the local anesthetics use, ropivacaine and bupivacaine has been the most used local anesthetics for continuous wound infiltration. At similar doses, the analgesic efficacy between the 2 agents seem comparable. Compared with bupivacaine, ropivacaine may possess a greater margin of safety and be less arrhythmogenic after accidental intravenous injection. So, which is why we chose to use ropivacaine in our cases. So when we developed our own setup, I started with the objective of doing something that is relatively effective, durable at a low cost, that is simple, quick, and carries low risk. So we bear in mind that often these laparotomy cases are quite long in duration, and the entire anesthesia and surgical team will be feeling quite drained at the end of the case. So compared to neuraxial blockades and peripheral nerve blocks, such as the erector spinae and the quadratus lumborum blocks that probably require more skill and generally a longer time for insertion, the pre-peritoneal catheters allow for continuous wound infusion, and I felt that would make a good compromise. Moreover, it can be administrated by the surgical team and can be done for almost any case unless they gave neuraxial infusion of analgesia for post-op pain. So I wanted it to be of low risk to the patient, especially because we use subcutaneous low molecular weight heparin for prophylaxis of venous thromboembolism in a significant number of these patients. And compared with neuraxial analgesia, this takes away the risk of things like a epidural hematoma or infection, which though uncommon can be morbid if it occurs. Okay, so to give everyone an overview of what we did, this is what the entire setup looks like. We used ropivacaine 0.2% filled into an elastomeric pump that will deliver local anesthetic at a preset rate into the pre-peritoneal space via epidural catheters. So it actually started when I returned from my fellowship in Australia, where pre-peritoneal catheters, which were essentially epidural catheters, were routinely inserted, and the LA was infused via an infusion syringe pump. So historically in NUH, we were giving patients with midline laparotomies combination oral analgesia as well as PCA opioids, either morphine, fentanyl, or oxycodone. So I started exploring with a fellow anesthetist doing something similar here. So you can see the PCA set where we allow an hourly bolus of 6 mL of ropivacaine, 0.2%, and we started using this T connector on the right-hand side to allow simultaneous infusion into two sides of the wound. So that was the very first setup. So over time, we refined our technique to allow standardization for ease of administration and to reduce medication errors. That was how we derived the latest setup, which you saw in previous slide. So then one of the anesthetists we worked with suggested that we use this multi-rate infuser elastomeric pump made by Baxter. That means that we do not have to rely on the limited numbers of infusion syringe pumps or the PCA administration sets. So these are low-cost disposable sets and allow for rates of 5, 7, or 12 mL per hour to be infused and have a capacity of up to 300 mL per bottle. So we used the epidural catheter with an 18-gauge 2E needle. I have enlarged the photo showing the curved needle tip, which protects the surgeon from accidental needle stick injuries during the insertion process, which is actually mainly by palpation. And there are 3 fenestrations at the end of the tubing that is threaded through the needle. So the 2E needle is the one indicated by the arrow. The nurse, during the laparotomy, fills the bottles up with 0.2% ropivacaine. So there's some amount of strength that is required to push the liquid into the reservoir that is within the bottle. Okay, this shows a real-time video which I took, and it is 1 minute and 38 seconds. So it illustrates our current technique in insertion of the pre-peritoneal wound catheters at the end of the laparotomy. So a point that is away from the area covered by the wound dressing is selected on each side of the wound. Then the surgeon lifts the skin up from the abdominal organs, and with the other hand inserts a 2E needle perpendicular to the skin until the needle tip is almost felt just above the peritoneum. The needle is then advanced parallel to the peritoneum, heading towards the ipsilateral anterior superior iliac spine. Now this is an attempt to ensure that the nerves are targeted at the most proximal point possible before they diverge towards the midline. And then the other hand ensures that the needle does not come through the peritoneum. Here we insert a bolus dose of ropivacaine dilute to make 20 mL to open up the pre-peritoneal space. The epidural catheter is then advanced through the needle until the last marking is seen. So that means about 20 centimeters of catheter would have been fed into the space. And then we withdraw the needle after that. So it is normal for the catheter to curl inside the in the pre-peritoneal layer and to retract slightly as the needle is withdrawn, but bear in mind the catheter only has 3 holes at the tip. So it is then connected to a crocodile clip and stuck down to the skin temporarily with a tegaderm. Then the process is repeated on the contralateral side. The laparotomy is then closed the usual way, mass closure with loop PDS, and the skin closed and then dressings placed. We can start the video. Yeah. Subsequently, the filter is connected and then the elastomeric pump connected. Okay, the rate is adjusted using the provided key to 7 mils per hour. And we can see that to indicate that the pump is working, sometimes you can see a bubble that is running through the tubing. And the reservoir also will shrink with time to show that it is working. So this last frame shows that the tubing is curled up and secured with a large tegaderm that is placed away from the wound dressing, because the honeycomb dressing is intended to be kept for a much longer time than these epidural tubings. And usually I place a drop of Dermabond at each catheter insertion site to prevent leakage. So the next 2 slides are a poster that we have put together and placed in the OT and wards to educate our medical team regarding this new setup, which is not new anymore by now. Determining the safe dose was done in conjunction with the anesthesia team. So the orders in how to order the medications in EIMR, the labels were placed on the bottle. The early and late signs of local anesthetic toxicities are also shown clearly in this poster. So when the patient reaches the ward, the setup is inspected daily to ensure that it is running at a preset rate. The reservoirs in the bottle should be shrinking over time, with the balloons almost being the same size bilaterally. The bottles can be topped up regularly in a manner similar to how it was topped up in the operating room. Patients have reported more pain if the top-up is delayed, as the ropivacaine needs to be obtained and surgical team needs to be available to perform the top-up. Sterility should be maintained in this process, and we are glad to report that there has not been any case of line sepsis so far. The duration of use of these wound catheters is dependent on the patient's pain score. So I've had medical colleagues who have been kept on these pain catheters until the day of discharge, because they could appreciate the difference in the pain with and without the LA infusion, especially between the top-ups. So I've actually also found these cases where ileus sets in and the patient is kept fasted and unable to take oral analgesia. This pre-peritoneal wound catheters are actually very useful. So it helps to cut down the opioid use at this time, especially so because the opioid can further exacerbate the ileus. So the rates can be adjusted based on the pain scores as well as the patient's weight. So for very big size patients, we have actually dialed up the rates about 12 mils per hour during the daytime when the patients are mobilizing, and then adjusted down during their sleeping time. So as the patient mobilizes, the bottles actually fit nicely into their hospital gown pockets, and alternatively, the company actually provides sling bags that are strapped across the patient's trunk. And then, we did have a case of a bottle falling out and the weight of the bottle yanking the entire tubing out when the patient went to the bathroom, but then there was no harm caused. So removal is actually performed very easily just by removing the tegaderm and pulling the entire tubing, making sure the tip is intact at the end of removal. Okay, so I come to the last part where we describe our own data. So in this last section, we'll just show you preliminary data from our own patients. This is an ongoing retrospective study comparing gynaecology patients who had undergone midline laparotomies. So we had 2 groups of patients. We used a group of historical patients who had, that was prior to the introduction of the pre-peritoneal wound catheters. That was in 2017. So we used a group of 74 patients. And then from 2018 onwards, when we started inserting these catheters, that we had 46 consecutive patients. So the main aim of the study was to demonstrate a reduction in PCA usage. The secondary aim of the study actually relates to the side effects of opioids, things like nausea, vomiting, sedation, itch, ileus, as well as catheter-related complications. So the data collected included patient demographics, for example, the age, ethnicity, diagnosis, type of surgery, the type of PCA they got, ASA classification, BMI. So the 2 groups are largely similar, but in the later analysis, I'll show you that any differences between these 2 groups were accounted for using the linear mixed effect model. Interestingly, there were no significant differences between the control and pre-peritoneal wound catheter groups for the following categories: pain scores at rest on the op day itself, which is day 0, day 1, and day 2. There was actually a lot of missing data for pain scores on movement, hence that was not included in analysis. Side effects such as nausea, vomiting, sedation, itch were not significantly different. Patients' recovery parameters such as duration taken to ambulate, taking orally, and bowel output were not different as well. The results were as follows. So there were a total of 120 patients, 76 in a control group, 46 in the pre-peritoneal wound catheter group. Although not numerically significant, I've put the side effects out here. You can see that the post-op nausea vomiting is 22% in the control group, whereas it's 9% in the wound catheter group. And with regards to the pre-peritoneal wound catheter group in the table on the right-hand side, average duration of use was 3.2 days. Infusion rate was mainly kept uniformly at 7 mL per hour, and there was no catheter-related complications such as leakage, blockage, breakage, retention, or infection. The use of PCA in the both groups are about the same, about 1.7 days in the pre-peritoneal wound catheter groups and 1.6 in the control. So this is the main result. So the graph summarizes the result obtained to answer the question as to whether there's a reduction in the dose of opioids administered with pre-peritoneal wound catheter use. So we use this linear mixed effect model combined with variable selection technique to find the variables that will make a difference to the dose delivered, correcting for all the other factors. So the dots show the estimates and the 95% confidence intervals for the regression coefficient beta. So they are colored in red when they do not include the value 0 and are therefore considered significant. So if you look at the chart and concentrate on the variables in red, anything to the left of 0, which is the dotted line there, means that there's a negative association of the factors stated with the total dose of opioids delivered. Example, the more number of days that have lapsed, the usage of the catheters, and the older the patients were associated with lower doses delivered via the PCA. Then we bring our attention to the variables on the right-hand side. Higher doses delivered via PCA were associated with those who had more pain at rest, those who took a longer time to start ambulating, and those of Indian ethnicity. And we also found that those who used fentanyl-containing PCAs also had used more doses. So bear in mind, we actually corrected for the differences in the opioid potencies. Okay, so from the results, we draw these conclusions that are stated here. So we have actually reiterated the primary and secondary endpoints. Firstly, the use of pre-peritoneal wound catheters reduced overall dose of opioids administered. Secondly, there's a reduction in post-op nausea vomiting in the pre-peritoneal wound catheter group. And thirdly, there are no catheter-related complications, hence it is a safe strategy to adopt. And I would like to thank the following people who in one way or another have contributed to our efforts to help improve our patients' post-op recovery experience. Thank you.
Thanks very much. That was quite interesting. I was just wondering, because the fenestrations for the tip are only at the end, does it make a difference how far inferior you actually insert your catheter?
Yeah, so as I said, the catheter is, we actually put at least 20 centimeters in. So when we draw it out, I think maybe a couple of centimeters would be out. But because it's right at the tip, and we infused this volume of 20 mils to open up the space, actually it didn't really make a difference.
So the level of anesthesia actually was able to cover the entire length of your incision? Because I presume the tip actually is...
Yeah, it will lie somewhere randomly in between.
Correct, yeah. But actually the patients all said that it was all numb.
So I think what happens is that because the space is opened up, so the volume infused actually bathes the entire area. And it helps. So some people question the fact that the tubings only, the holes are really right at the end, and they generally should be along the entire tubing for effectiveness, but we found that it works equally well.
I have a lot of technical questions about this wound catheters. So when you place the epidural catheter, you're trying to aim as superiorly as possible.
Okay, if the wound, depending on the length of the wound, I try to start as superiorly, as carefully as possible, but sometimes it's not possible because of the ribs. So I just start at a level, a reasonable level. Sometimes you'll miss the top end of it, but just try to direct it as proximal to the as into the spinal cord as possible, if you can put it that way.
Okay. So I would assume that it's technically more difficult the thicker the abdominal wall. So obese patients, because there's the length of that needle, it's a certain size only lah.
Yeah,
So
so
do you have any problems?
So far, we didn't have any problems with that, but yeah, I don't think we have any patient whose abdominal wall is thicker than this, but I imagine one day we will encounter that. But I think there are longer needles to counter this issue.
Okay.
Yeah, actually these are the epidural needles that we take from the labor ward, so we got the idea from there as well.
So it looks particularly useful for laparotomy wounds, but in laparoscopic surgery for extraction site wounds, I would think that it would be helpful. So if it's a transverse incision, you would also sort of just aim on both sides laterally?
Yeah, so actually for patients whom I give a transverse incision, I actually just give a single shot to both sides using the same TUI needle. I mean, the reason why I use a TUI needle is because I just don't want to hurt myself. Some people use the normal needle to inject the local anesthetic, but I find it's very dangerous. Like you don't really know how deep it is before it reaches your finger. So I use the same needle, but I deposit like 20 mils of Ropi on each side. And generally works quite well as well.
So you don't put in a catheter in
Yeah, I don't use it as an infusion, but I suppose you can if you want to, but so far we haven't had patients with a lot of pain issues with a transverse.
Yeah, because usually the suprapubic transverse incision are associated with less pain.
Yeah.
So those you don't put in. Okay, then finally, the papers that you were discussing, there was one where they completely did away with PCA. So how come in your study for these 2 years, the patients had both the catheter as well as PCA? Would you consider removing PCA completely in the future?
Okay, actually out of the 46, right, 9 didn't have, but it's a retrospective study and we just started it, we just started it one day, and I think it also depends on the anesthetist who is with us. Some of them will say, oh, let's just see how effective this is. We can always give the PCA in the recovery area if the patient has a problem, or we can set it up later. I guess it depends on the anesthetist whom we work with. So it's actually quite good collaborating with them and having a discussion.
Is that a question?
No, it's not a question. Oh, Hong Jie has a comment. He just said that the whole cost of the entire setup is about $60.
Yeah, it is relatively cheap.
It's amazing because the on-cue I think is about 200 plus. So this is, I congratulate your innovation.
No, actually, I think in NUH, I think it's about 400 plus. That is without the ropivacaine.
Without the medicine.
Actually, I think it is a bit more expensive than what Hong Jie says. Because each bottle is, I think, 45, and the needles, if you want to count, the needle set itself is about 28. So then you do times 2 because we use from both sides. The cost of ropivacaine will be the same. But the best part is we could top it up in the ward. It is probably unlabeled to top up. But we imagine that with the topping up, the rates actually slow down. I mean, if you imagine the elastomeric capability will not be as good as the initial time. So if anything, it will be erring on the side of safety rather than being dangerous.
Okay, we have one question from
Hi, Dr. Po. I'm one of the surgical residents. Thank you for the very insightful talk. I actually just have a question because in GS we tend to use the on-cue pump, which is a little bit different from the system that you showed us in your video earlier. I'm just wondering what the advantages of the system that you had versus the on-cue pump. And if you have experience between the different types of systems and why there's a preference in ONG for that particular system in the video that you showed us. And the other question is that we tend to be hesitant to use it in surgery when we have a gross intraperitoneal contamination or we have an infected field. And just wondering in the study that you did whether you have any experience with this and whether there's a concern with regards to intraperitoneal contamination when using the on-cue pump. Yeah, thank you.
Thanks for your questions. They are very valid concerns. So with regards to the first question, I must be honest with the fact that I've never used an on-cue pump. So since I came back, I've used the epidural catheters because that was what I was trained with. So I've watched people use the on-cue pump, and I don't know whether it is actually easier or more difficult to insert. So I think it's also once I started it, I've never actually, and because I don't think there's any, cost-wise, it was not something that was a problem. Availability was not a problem as well, so I've just stuck to what I have been comfortable doing. And it was quite easy because I think initially when I came back, some people showed me they had to stitch down the on-cue, the tubings, but for mine, I just stick a tegaderm and be done with it at the end of a long case. Second question in regards to peritoneal contamination, because we don't go into the peritoneal cavity for this, it's actually in the pre-peritoneal layer. So there isn't actually a concern with peritoneal contamination. In any case, I mean, if there's any contaminated case, I would imagine there will be a washout being done, there's a drain being placed as well. The only thing I was not very sure is that in cases where we have peritonectomy done, especially those with some pelvic peritonectomy, yeah, that is one, I'm not, in one case, I'm not sure whether it is still effective. It appears to still be effective. I mean, we have small numbers, but I think at the end of the day, we're trying to expand these retrospective studies. I guess we will not be able to ethically carry out a prospective study in that sense. But maybe with more numbers, we could see what about patients who had stoma placed or who had a peritonectomy, whether it's actually as effective.
So thank you very much.
Thank you.
Thanks very much.